Thank you for the wonderful introduction, Keith. And I'm partially here in my hat, I guess, also as an infectious disease clinician, and having dealt with patients with tuberculosis or concerns about tuberculosis for that part of my training and career. And really, there was a wonderful opportunity that came together 5 or 6 years ago, originally under the leadership of Dr. Koelle and then with Dr. Jerome, to bring in this test for immunity to tuberculosis onto as an online test, and really helped me to bring together my clinical interest and experience with the laboratory medicine and cellular immunology side, because this is a T-cell test. It's a cellular immunology-based test for immunity to Mycobacterium tuberculosis. So that's going to be the subject for my talk today. And I'd like to thank, in addition to Keith and Larry, the individuals in the clinical virology lab, Anne and Greg and Roxanne, who are really the primary people responsible for this test. Chris is a research technologist in my lab who has also helped a lot. And the individuals at the bottom are at a research institute in India, where I was lucky enough to go on a brief sabbatical in 2013 and do a little tuberculosis work there also, which I'll just very briefly mention. So learning objectives are required for the grand rounds, and I've listed these here. I can summarize as how does it work, when should you use it, when should you not use it, and what are you going to do about those indeterminates, which we do have a test here which sends out 5 to 10% results that don't say positive, don't say negative, they say indeterminate. So those are sort of the 4 learning objectives. In terms of disclosures, we are involved in evaluation of a next generation test over at the virology lab, but it's a fairly minor thing where we're just testing a few samples, and that's about it for disclosures on this. We do have a research arm too, and I'm just going to mention these themes and show one slide, and that's it. Really, the bulk of the talk today is going to be about the clinical test and the experience with the clinical test. This test is a candidate test to replace or augment the tuberculin skin test. We think of the PPD, the MAN2 test, it's got a bunch of names, TST, tuberculosis skin test. And the Centers for Disease Control, in their recent cycle of the NHANES study, a national EPI study, did 7,500 people where they did the quantiferon test, the IGRA test, and the skin test. And Dr. Horn, David Horn, who's in pulmonary here, is working with that data set. We actually had the contract here where we ran those 7,500 tests in our lab for the CDC as part of the NHANES study. We've noticed that sometimes we get high values in the test that we can maybe explain by immune activation, and there's a theme in HIV medicine that patients with HIV have inappropriate or spontaneous immune activation. So together with some people at the Madison Clinic, Suresh Danareddy and a trainee, we're looking at this issue of high NILS or immune activation. As I mentioned, we are testing a next generation test, a little bit with the manufacturer, and David and also Masa Narita from the Public Health Department are working on that. And I did, as I said, have a brief chance to go to India and work in this wonderful research center. So labs are labs, and things look kind of the same pretty much all over the world. Did have a little recreational trip there, but we really like just to turn attention now to just a few facts or pseudo-facts about TB that are sort of the received or conventional wisdom and give a little bit of the scope of the problem. More than 1 million people a year die of tuberculosis around the world, so it's obviously a major infectious disease challenge. There's a partially effective vaccine, BCG, that many people get around the world, may protect against pediatric disseminated or meningitic disease, doesn't really protect against the adult, more routine pulmonary disease at all, but does complicate testing. About 1/3 of the people on the earth have living Mycobacterium tuberculosis in their body, as far as we know. They have immunity to MTB, they're positive by the skin test or positive by the test we'll talk about today, and are at risk for reactivation. So this is really an extremely prevalent condition of being infected with MTB. And the BCG vaccine actually does complicate the skin test. I used the word ruins there, but because the bacteria are so cross-reactive, BCG is a live bacterial vaccine, leads to immunity, and that immunity cross-reacts with that PPD stuff that you get that little bubble under the skin. There's a lot of cross-reactivity, making it difficult to interpret a positive skin test in somebody who's had BCG. So one take-home from today is that the IGRA tests, the ones I'm going to talk about today, are not affected by BCG vaccination. So you can see a potential advantage there. We have such an international population, so many people working in our healthcare system and our patient care population who have had BCG, that these blood-based tests are not interfered with by BCG. We think infections are permanent. Now, we don't actually know that, but we think that everybody who gets infected and develops an immune response has a few mycobacteria in some pulmonary macrophages somewhere in their lungs and is at risk to reactivate. Sort of received wisdom. It's not actually sure that that's true. We also think that people stay seropositive, if you will, or stay immune for their entire life and that immunity never wanes. We really don't have a lot of great evidence for that either. The next bullet point is the one that we all learn in clinical medicine. Your lifetime risk of progressing to active TB infection, ATBI, active TB, is maybe 5 to 10% over the course of your life. So among those 1/3 of people who are infected, up to 5 to 10% of them may relapse or develop active TB due to recrudescence at some point. We really wish we had a test as to who was at risk, who's in the 5% and who's in the 95% to go on to reactivate their TB. If we had that, boy, then we could target those individuals for therapy, for antimicrobial therapy, and not worry so much about the other 95% of the 1/3 of the people on the earth. These tests I'm going to describe today do not do that, although there's a great, huge effort to find biomarkers that could be in the acquired immunity realm or innate immunity or host genetics or something that we can sort of stratify who's in the risk to relapse and who isn't. And I sort of mentioned the sort of dichotomy of latent TB infection versus active TB infections. Newer thinking of this is that there's more of a spectrum rather than just a dichotomy between two states. Going anywhere from at the bottom, the mildest end of the spectrum would be that infection is eliminated by innate immunity. Somebody inhales or gets exposed to a few TB bacilli, and you don't even get an acquired immune response. You just clear it. You just deal with it. Or maybe at the second point here is that you eliminate the infection completely, but you still are seropositive. You're still going to be positive for immunity. We don't actually know if this occurs either. This is what we usually mean by latent TB infection. The infection is controlled and walled off in some granulomas, typically in the lungs. There is immunity. We can pick up by a skin test, pick up by our blood test. And then with immune suppression, maybe with they're showing effective HIV here, you go on to clinical disease. The point here over on the right is that all of these states where one has immune reactivity are going to lead to a positive either skin test, TST, or our today's subject, the IGRA test. And you cannot tell from the test what state the person is in. So another take-home point is the IGRA test is not a test for active TB. It cannot differentiate between latent and active TB. Ergo, somebody sitting in your emergency room in your hospital with fever, cough, infiltrate on their chest x-ray, does it make sense to get an IGRA test to try to figure out do they have TB now or not, active TB or not? It does not make sense. Therefore, many inpatient tests, and I would say 99% of all emergency room tests are misguided. And I'll show you some statistics a little bit later on about how many inpatient and emergency room tests actually get ordered. But this is kind of an outpatient medicine test. It's a test of the long-term health status of the individual. Do they have immunity to Mycobacterium tuberculosis? It's not really a test for what does this person who's sick in front of me right now have. Okay, so first learning objective, understand how the test works. We need to know that MTB has about 4,000 genes that encode 4,000 proteins, includes a particular region we'll come back to, the RD1, that includes a couple of proteins called ESAT6 and CFP10. And the antigens in these tests typically contain peptides from those two proteins, those two special proteins, and maybe a third, there's a third protein represented in one of the tests. And these particular peptides are actually antigenic for memory T cells in the blood that upon recall, upon seeing these peptides, encountering these peptides, they can spit out Interferon-Gamma. So just a little bit more graphically, what are we looking at? Here's the person. And when the person first becomes infected with tuberculosis, they've got some naive T cells in their blood, a non-zero level, an antigen-presenting cell. This might be a pulmonary macrophage or something like that. It's infected with TB. Here's that naive T cell. It's going to stimulate that cell to replicate and then be represented in the blood, a bunch of memory CD4 T cells. So this could be your typical person with LTBI, an immigrant, a new hire at your hospital or whatever, who's perfectly healthy. They've walled off the MTB just in a few bacteria in their lungs, but they now have an increased pool of these T cells in their blood. So in the lower part of the picture here are the 3 tubes for the quantiferon test. We'll come back to this in a minute. There's memory T cells sitting in those blood tubes. And what we now do is we add the peptide here. So we're putting back in this little cocktail of peptides. if the peptides are then, if the T cell here encounters those peptides, and I'm not going to go into these molecular details here, but enough to know that the T cell is specific for the peptide, it's the green item here, encounters that peptide, then those memory T cells will become activated. And one of the things that they'll do when they become activated is in very short order, we're talking 16 to 24 hours or right away, is that they'll secrete a lot of interferon-gamma. And that's what we detect in the interferon-gamma release assay. So IGRA, interferon-gamma release assay, we're detecting the secretion or release of interferon-gamma by memory T cells that are specific for Mycobacterium tuberculosis. The history of this test is actually really kind of interesting. The origins of the test are in Australia, and it was developed for veterinary medicine. Turns out that Mycobacterium bovis is a big deal in cows, and you have to cull those cows from your herd, and you can't use them for meat, and you can't use them for milk, and so forth. And what they used to do in the old days is they did a skin test on cows, and that's what this guy is doing here. He's taking a needle, and he's on the udder of the cow, and he's actually injecting intracutaneously some sort of tuberculin for Mycobacterium bovis, sort of a dead antigen preparation. And then the person's got to go back, 48 to 72 hours later and look and measure the swelling on the cow udder. And if it's all inflamed and everything because of infiltrating specific T cells, then that cow is infected and that cow gets culled. And this seemed sort of primitive and laborious. So scientists in Australia said, let's see if we can develop a blood test that we can look for interferon-gamma release in a small sample of the cow's blood. And they did that originally using a crude filtrate preparation of whole Mycobacterium bovis. And in this case, they actually had a gold standard. In the study I'm going to show you on the next slide, they did this on over 100 cattle, and they were who were infected, because at necropsy, they dissected the cows and they put every organ they could think of onto appropriate Lowenstein agar or whatever, and they had a gold standard of infection. And in this study, 125 cows were actually infected. And they looked at the sensitivity of these different candidate tests. And this is the bovine tuberculin skin test. It was 65% sensitive. But the interferon-gamma release assay was 94% sensitive, and then if they said you can be positive for either test, it increased it up to 95%. So this is actually back in the late 80s, and this led to the scientists getting involved and saying, can we do this for humans by having an ex vivo interferon-gamma release test for human medicine? The first couple of generations of this, they didn't use these fancy peptides. They actually just used PPD. They took a blood sample, purified the white cells, and threw in some PPD, skin test reagent. They've improved on that, and I'll go into the generations in a second of that. But this is sort of interesting. It's the history of this test that lies in veterinary medicine. This cartoon here just shows the genomic organization of a very small part of the MTB genome, and the two little blue open reading frames, they're really tiny little proteins. These are the ones that we make the peptides from that are involved in the current generation test or in the modern test. RD1, that stands for region of difference 1. Difference between what and what? The difference between MTB, virulent MTB, and BCG, the vaccine. So David Sherman, who's actually here in Seattle, about 15 years ago, published on this that there are just a very few regions of difference between these two bacterial species. And one of these is this region of difference 1. Therefore, these proteins are not present in BCG. So the principle that we're able to differentiate between people who are BCG immune from people who are MTB immune is that these genes are absent in BCG. Okay? But there's always a but. These genes are actually present in a couple of clinically significant pathogens that I've listed there. So this is more for Ajit and the aficionados, but occasionally humans are infected with these other mycobacterial species that you see here, and these would lead to a positive, call it a false positive, call it whatever you want, but lead to a positive interferon-gamma release assay because these bacterial species also have these genes. Okay? NTM is non-tuberculous mycobacteria, and then there's the TB complex. So let's look at the way the test actually looks kind of in practice. And I sort of a visual thinker and like to pull things off the internet because it's convenient. So sort of go through this step by step, but you start with these fancy specimen collection receptacles, and unlike almost every other test I can think of, these are very specific high-tech blood tubes. The chlamydia swabs and a few of the other microbiology tests we do, there's an expensive high-tech collection vessel that's usually it's just your standard purple top or marble top or whatever, or it's a sterile urine cup or something. So one of the pain points of this test is that these tubes have to be perfect, and we'll come back to that. The whole blood is drawn, there's anticoagulant in the tubes, you've got to get it to the lab pretty quickly, and then we'll just go through this process a little bit step by step. So there's a tube triad. There are 3 tubes, 3 1 mil draws, and you're always going to get 3 numbers when you get the result also off of this test. One of the tubes has nothing in it. And since this is Australian, British Empire, we call it nil. It's nothing is nil, okay? And then the next tube, the red tube, has the TB peptides in it, and they're these synthetic and they're lyophilized. And imagine if you got a little endotoxin or a little bit of contaminating junk in that tube. That would be bad, right? Because that could trigger interferon release from the tubes and lead to false positive tests. So that's what my summer of 2012 was preoccupied with. So this is a potential pain point. These cells are so hair trigger, and release of a little bit of interferon leads to a positive test, that these reagents in these tubes have to be clean, clean, clean. And then the third tube is a positive control substance. It's a mitogen or a stimulant that stimulates Interferon-Gamma release non-specifically from all lymphocytes. And we'll come back to this. It's a protein called PHA. So that's the high-tech tube triad. Got to be at the right temperature. The tubes have outdates on them. They're purchased by your phlebotomy or your outpatient clinic separately from the in-lab phase. So you've got different people buying things and stocking things. Lot-to-lot variation, yep, that can occur. And then you'll be mixing and matching the 3 elements of the triad, maybe from different lots in the triad even. So that adds another level of complication. The phlebotomy itself also needs to be done perfectly. You got to have 1 mil in there. 0.9 isn't good, 1.1 isn't good because you're changing the concentration of the reactants in there. If the blood hemolyzes, that's a problem. And then the shaking, 10 karate chops has been what's sort of described. So if the phlebotomist, whoever is doing this, just sort of slowly draws the blood into the tube and lets it sit, the blood cells won't get mixed up with the peptides or mixed up with the mitogen, and you'll get a false negative reaction or a poor reaction. So that's extremely important. And things that are a little more theoretical, or if you're drawing from a line in the hospital and there's heparin or there's something in there, if there's a bunch of Staph aureus on the skin and you try to clean it, but you go through and there's a superantigen or something stimulatory in there, that could be bad too. So I think you'll see this when we look at the statistics for the indeterminates. This is a huge problem, I think, inpatient, because you think the way the inpatient floors work. Patients are sick, they're in the unit, there are nurse draws, there's a shift nurse or whatever, versus outpatient where there's phlebotomists who are under our control who we can highly train to do the draws perfectly. So our problem rate is much lower in the outpatient than it is in the inpatient, and I think this is one of the reasons for that. So even the collection vessels themselves and the phlebotomy is not super straightforward for this test. You got to get it to the lab within 16 hours, and you have to avoid temperature excursions because you're expecting living lymphocytes to still be in that tube of blood. Gets too cold, gets too warm, you're done there. And we're paying a lot of attention to the delivery time and the transport time to the lab. The next in-lab steps, we shift the cells up to 37 degrees in the incubator. That allows the reaction to take place and for the lymphocytes to get stimulated and make interferon. That's pretty straightforward. We spin and save the plasmas. This helps us. We can batch things by saving the plasmas. Then the company supplies an ELISA kit, which is a very straightforward thing where we're just measuring the amount of Interferon-Gamma by ELISA in the plasma phase after we spin the blood. And we do have standard curves on every plate, and we have validation samples and so forth that we use to make sure that that step is under control. And that step really hasn't been that big of a problem. And at the end of the day, you get a report. So that's sort of shown down here. Here's a typical report. It's got 4 parts to it. 3 numbers for the nil, the MTB, and the MIT is the mitogen, and then an interp that's kind of a algorithm driven that we review, but it's really driven by the numbers. And so we're handing clinicians not just a yes, no, or no result. We've chosen to hand them the 3 numbers. Some healthcare systems, they just hand them the interpretation. They don't hand them the numbers. But we think that there's actually value in the raw numbers, and that this can help the clinicians make a more accurate contextual diagnosis in the context of the subject's particular situation. But maybe arguably could be adding to confusion that, like, well, what are all these numbers? Well, just give me the answer. Is it positive or negative? So that is a little bit of an issue there. The core of the interpretation, and I'm going to briefly show the interpretive algorithm later, but the core of the interpretation is that if the amount of interferon in the TB tube is higher than the amount of interferon in the nil tube by 0.35 units, so if there's a delta there where there's more interferon being released with the TB peptides, it's positive if the negative control is decently low, Okay, so with the tube with nothing had very little interferon, and the mitogen tube, the positive control is decently high. So there's sort of a nested set of logical statements, and if these conditions are met, then the result is reported out as positive. So I'll show you the actual numbers on the algorithm in a minute, but that's sort of the core. Again, if neither one of these conditions is met, if the nil negative control is very high or the mitogen positive control is very low, then you have a indeterminate result. Okay. So why do we, who is indicated to get this test? It's actually, even that is a little bit controversial. And experts in the field sort of say this is the bottom line criteria. The test result needs to be actionable. And that may seem like, common sense, but we do a lot of TB testing because it's in the state law. I think the tuberculosis is mentioned in the Washington State Law Code something like 26 times because of concern from, how things used to be worse in the past, and, orphanages and hospitals and institutions, and there's a lot of angst and history around TB. So not all of the testing that we do is terribly rational, but you could split it up into either personal health rationale or public health rationale. And I don't want to go into this in great detail, but if you have LTBI and you have an upcoming risk of conversion, like you have upcoming immune suppression or ongoing immune suppression, that makes sense. And our lead customer is sitting right behind Keith here. Actually, Transplant is the biggest customer of our test, biggest user of the test, because those individuals are all already heard of immune compromise, but they're going to go on to more extreme immune compromise. And then the clinics such as digestive disease clinics and musculoskeletal arthritis clinics are also very big clients because of the biologicals they're giving now, anti-TNF and other therapies that specifically can hurt the immune system and lead to reactivation of TB. Arguably, if somebody is coming back or is going into a situation where they might get exposed to TB, like they're going to travel in the developing world, they're a healthcare worker, they've been in jail, something like that, where they might be exposed, that these might be indications for personal health. But we do some of this testing actually with a public health rationale, where we're trying to identify people who might have active TB, and we're using this test, or might be at risk for active TB, and we're using this as kind of an entree to that. So I know that the ICE, the Border and Immigration Control people, they're starting to use quantiferon instead of the skin test now, because it's still sort of mandated that when people come into the country, they should have an evaluation for latent TB, and if it's positive, they should get a chest X-ray and sort of a history and so forth. So, and I don't think that we have those people's personal health in mind. I think it's sort of that quarantine public health mindset that's going into that viewpoint. So in terms of the first learning objective, how does it work? It's really T-cell memory to LTBI peptides. This should be TB peptides, MTB peptides. The positive test can't distinguish latent from active. Some non-tuberculous mycobacteria infections can lead to a false positive, but BCG vaccination can't lead to a false positive. It's susceptible to manufacturing and pre-lab variables, and just like the skin test, and we're going to come to this, it's also susceptible to immune suppression leading to a false negative. So you can still have an okay mitogen response and get a false negative here if you're immune suppressed, because it does depend on immune reactivity. So what are some situations where it's useful? Okay. What's the competition? The skin test has a long and fascinating history, but it's basically the substance is a supernatant of an MTB culture that's sterilized and so forth, and it has some problems. It's susceptible to false negatives in immune suppressed people. Also, if you have active TB, you can have a false negative. You need a skilled nurse to administer this. The person has to come back in 48 to 72 hours. And until recently, it's been hard to get the results into the electronic medical record, where it's not a number. It's sort of an obscure little measurement that has been hard to know where to chart that. But the biggest point is the third point here is the false positives with BCG vaccination. So that's really the biggest problem with the tuberculosis skin test. And it's been argued, if this is sort of a map of the world, and the red countries are countries where people get BCG multiple times. They're either getting it after infancy or they get it at infancy and then multiple times. So those are the countries with the worst problems with false positive skin tests. People have argued that the yellow countries, so the US and Greenland, I think, or the US and Australia don't give BCG, but every other country in the world, all these African countries and these other Latin American countries do give BCG, but they give it in infancy only. And the argument's been if you only get it once in infancy, you're not going to have that much of a problem with a false positive TST. So I'm not sure what the actual final data on that are, but there's been somewhat argued about that. The third generation test that we now run steps around some of that, and you can read the first and second generation if you want, but then the third generation test, it's a whole blood test. We don't have to purify white cells from the blood, and it avoids the BCG problem because it just uses peptides. The fourth generation test is coming, and we're evaluating that. It just adds some additional peptides. So let's look at a case where this is actually a real case, and where this test is really appropriate. This is a woman, 56-year-old woman, who has end-stage renal disease and is all dialysis and was seen at the pre-kidney transplant clinic, and she has no history of TB. But her laboratory, here's her triad of numbers. Her NIL was 0.02, her TB was 2.74, so that delta, if you minus that, was greater than 0.35. Her mitogen maxed out the test, and her chest x-ray was negative. So these results were communicated to her nephrologist, who started her on treatment for latent TB infection. So this is a once-a-day antibiotic for nine months. Turns out that this patient was seen at our ID clinic with some nausea and some problems with taking the isoniazid, and she was changed to an alternative therapy for the latent TB infection, and that's why she was seen here. But this is a person who probably got BCG as a child, so the skin test isn't so good. She's headed for sure for more immune suppression if she gets the kidney transplant, and we would just like to sterilize her and kill any residual live MTB bacteria before she goes into the immune suppression. And this is, I think, another example of a reasonable situation of somebody from Brazil, an endemic country. They're starting work just on the hospital staff. They had BCG a bunch of times when they were young, and they actually refused to get the PPD test. They refused the skin test because it always leads to this really nasty big thing on their arm, and they're saying, this is just from my BCG when I was a kid, and I won't have the test again. So they have a QuantiFERON test, and we see this kind of result a fair amount. They maxed out the test. They blew the test out of the water with the MTB greater than 10. The questions in chest x-ray and everything, they didn't have active TB infection, and the diagnosis was latent TB infection, and they got 12 weeks of therapy prior to starting their job or at the time of starting their job in the hospital. So this is another case of appropriate use. I think I already showed you this slide. So in terms of the second learning objectives, appropriate indications, previous BCG, especially post-infancy. If there's a high local incidence of some NTM infection, that can be, it's like getting BCG, so this might be the southeastern US. Some of the NTMs do cause positive, so fish finger, if you're working up in the fish processing up in Alaska and you get Mycobacterium marinum, you're going to have a positive test here. If the patient's unlikely to return for their second test, and we all who see patients have this kind of experience, this is a little bit arguable because if the patient's not going to come back at 48 hours to have their skin test read, if you get a positive QuantiFERON, if this is a difficult to reach or unreachable flighty patient, then you have a non-actionable result. And this is my problem with the ER usage. Why are we using this test in the ER where recontacting is sometimes quite challenging in that situation? But if the patient just can't come back, that might be an indication for using this. 1 in a million people have a real hypersensitivity to PPD, to one of the components in PPD. And it's arguably the cost and convenience and maybe trackability in the EMR. But the main thing is that a positive or negative test is actionable, that there's a value for the test. Okay, so what about inappropriate uses? And this is where I'm going to get into some stats on our actual experience here. So this is just the way the volume has looked since we started the test in mid-2009. And you can see we're doing about 500 clinicals a month at this point with the test. So we can try to evaluate how's the test performing and also what of this is appropriate and what is inappropriate. So that's going to be sort of the themes that I'm going to go into on the next couple of slides that really review the real life use of the test here in our system. So overall, what are the ordering units? So we've resulted about 20,700 tests. There are 18,000 outpatient, but there were 1,800 inpatient tests ordered, and there were 206 ER or ED or ED OBS or different sort of emergency room designations between Harborview and UW-MC over this 5-year period. And I would really argue that almost all of those ER uses are just, you're not going to diagnose active TB with this test if the person's in front of you. It takes a day, day and a half for the test to come back anyway, and it doesn't help between latent and active, and chances are you've discharged the patient from your ER anyway by the time you get the result. We'll come back to the inpatient in a minute. So I really see the ER use as a problem. And just looking at a high-level summary of the results. So down here is a high-level summary of all of the results, where our positives are about 6 or 7%. So that's about where they should be for a mixed U.S. population. So, and about 85% of them are negative, but there's this big bad green slice, which is the indeterminate slice. So this is just the overall summary of our results since we started doing the test. And if we divide this between the outpatient tests and the inpatient tests, I think you can immediately see that the proportion of indeterminates on the inpatient side is much higher. And why is that? First of all, how many of these tests are appropriate? Maybe a few of them. We could argue about each one. But why are so many of these tests indeterminates? It's probably in two families of reasons. One is the patients are sick, they're immune suppressed, they're malnourished, they're on steroids, or different reasons that could lead to low mitogen responses, so uninterpretable responses because that PHA result is low. So we've got a much sicker population on the inpatient side. I also think we have a much wider variety of phlebotomy scenarios going on with nurse draws and they don't know they're supposed to shake the tubes, or there's some heparin in the tube because they're drawing it out of a line or something like that. And it's just really hard to standardize things as well as we can in the outpatient side. So with Mark Wenner, I'm not sure if Mark is here, but we've had some attempts to have educational sessions with the phlebotomists, and that's easy to do with the phlebotomists, but up on the floors and in the units where everybody draws blood, it's a little bit harder to teach about this. So when is an inpatient draw even indicated? When does it make sense? Well, as Ajit and I have talked, if you're pre-liver or you're pre-kidney and you're so sick that you're just admitted and you're probably going to be here or pre-heart on your LVAD or on some sort of maximal dialysis until you get your organ, and you need to sort of hurry up the workup, yeah, that makes sense. Or if you've got terrible Crohn's disease or terrible rheumatoid arthritis and the physicians want to start biological modifier immediately to deal with this, and they want to get the infectious disease preventative workup done, then yeah, probably an inpatient test is indicated. But if you're just sort of checking off a checklist of tests, like somebody with a new diagnosis of HIV or something, or they're eventually going to get on the liver list or something, I would argue this is really an outpatient test and is not quite so appropriate for the inpatient use. So, indeterminate and indeterminate, I probably don't use the words correctly. One's an adjective, one's either way. But either way, it's a big frown. And what can we sort of do about this? This is the way it should be. So these are these 7,100 tests that we did for the CDC. These were mostly healthier outpatients. They were people who were well enough to walk into a trailer and undergo these epidemiologic tests. And our indeterminate rate, we did those here, same lab, same text, same machine. Our indeterminate rate was 0.4%. So, there's nothing wrong that we're doing in our lab that's leading to this. It's really the pre-lab phase, patient selection and phlebotomy side. This overall positivity rate was really near the US trends. And we wish our results could look this clean. So if we delve into our results now a little bit tighter, this is time, there's the volume up here. The reds are the negatives, the blues are the positives, and then the greens are the bad guys, the indeterminates. And what you can see here is, last fall and going over the new year and then leading even into now, the green line has perked up. Okay, suddenly, this was bad before where we were getting 5% indeterminates. Now the lines have sort of crossed and we're getting a lot more indeterminates. And it got bad, and maybe it's getting a little better now, but it's still not as good as it was before. And we looked at this analytically, and this is actually Ajit's recommendation, is we said, okay, well, maybe the indeterminates are just having a longer delay to get to the lab. Remember that race car, the Ferrari, and the sample's got to get from the patient's arm to the lab. Could there just be a delay there? But we actually looked at the sort of a histogram of the time frame between draw and upshift of incubation, and there really wasn't any difference. So we couldn't just blame it on lab delay, leading to indeterminates. And then the company, sent out a little notice or something like that that said that they had changed that positive control. They had changed the mitogen. They didn't call this a recall like they did the time when they put the endotoxin in the tubes, because that other one led to false positives. And this one just has led to more indeterminates. So it didn't meet whatever the criteria are for a recall, but it certainly led to a lot more indeterminates in this situation. They changed batches of their mitogen, of their PHA. And there was not a bioequivalence in the old batch to the new batch when they changed this. What is PHA? It's this really cool protein. It comes from beans and kidney beans and cannellini, which I'm not sure what those are. But this is, it's a bioproduct. It's made actually by aqueously boiling up beans and then taking the proteins that are in the water phase and purifying this protein. So it's a multivalent protein. It's biologically fragile. It actually works by, it cross-links the cells to each other and also activates them. So it seems strange that we should have this bean filtrate protein in there as the positive control, but that's still what we're dealing with. And to take just one sort of finer grain look at this indeterminate problem, now splitting it up into the outpatients and the inpatients, there's that same trend there where even on the outpatients, the line's crossed over and there's more indeterminants and it still hasn't gone back to where we'd like to see it. On the inpatient side, look what happened. We were faced with higher indeterminants to begin with, so this is about 20% on the average. And then when the problem came in, it went up to as high as 50%, 40 or 50%, and it still hasn't really healed itself up, or we haven't been able to heal it. What the company did was they said, uh-oh, we switched things. Here they switched to a third batch, but it's so hard to get this tuned just right that it looks like they haven't been able to mimic the first and original batch. So this is a G. Make me feel better. There's a problem here. So we actually, there are 2 FDA-approved interferon-gamma release assays, and we've been exploring using the other one, which I'm going to describe briefly now. So I mentioned about the quantiferon. That's the main one that we use. But there's another one that's an ELISpot. We're currently sending it out. We're sending out about 15 a month on these. And it uses mononuclear cells that are purified from anticoagulated blood. So this is handling, this is processing, this is centrifuging, this is a hassle. We have to purify out, or the reference lab purifies out the cells. But the readout is an ELISpot that actually counts and detects the TB reactive cells. And these are what some examples of some positives and negatives looks like under the microscope. This is a 96-well plate. Positive control is here, lots of dots. Negative results are here. These same 2 proteins, if you'll notice here, they make peptides from those same 2 proteins. Each one of those dots was a cell. So there are certain interpretive criteria for the number of dots you need to have, but this test has some possible advantages. So what's our experience here at UW? I looked at the last 40 that we sent out in the last couple of months, and they almost all came from these different pre-transplant scenarios of the different organ systems that are represented here in the transplant world. And these were all subjects that had had prior indeterminate quantiferons. If you were red, you'd had 1 indeterminate, but some of the people had even 2 or 3 tries here to get an interpretable test, and they just kept having indeterminates over and over again. So finally we just said, okay, we have to send these out to try to get a definitive result prior to transplant. And the way the results came back are here. They were almost all negative, except then there was 1 positive. And if you break this down, that was kind of nice because that 1 positive had a prior positive quantiferon. So they were positive by quantiferon, and they were also positive by the T-spot. So hopefully we were able to accurately resolve for these sort of mission-critical patients. We were able to accurately resolve their status and give the transplant physicians some security in whether they needed to give TB therapy, or not. So back on the theme of useless tests, though. I think I've given you some scenarios, but this is the kind of inappropriate use that we see quite not uncommonly. An older man, he's from a TB endemic country, and he presents to the hospital or to the community clinic with cough and fever, and he's got an infiltrate. So chest X-ray is abnormal, and you're admitting the patient and isolating, and you're collecting sputum and treating for community-acquired pneumonia. The sputums are pending and so forth. And the question is, will a quantiferon test be useful, and why or why not? So I've already implicated this in the previous discussions of the lecture, but if it's positive, does he have TB disease? Not necessarily. He's from an endemic country, so he doesn't need empiric 4-drug therapy if he's positive. If he's positive, does he have LTBI and he needs treatment at some point for latent TB infection? That's probably arguable. An elderly gentleman, whether he really needs latent TB, guidelines would probably say yes, but this isn't an inpatient or acute, issue about whether he needs this or not. If it's positive, do you have to screen the families and contacts? No, because we don't know he has active TB. If it's negative, is that useful? Does that mean he doesn't have TB? No. So both the skin test and this test, you can be sick and have active TB and have a negative test. It's the anergy of extreme illness and immune suppression related to TB. So the correct answer is useless. then this is just somebody who you would not order this test on. Another situation here, somebody who's had treated TB. So here's a man from India. He's been seen in the HIV clinic. He had pulmonary TB in childhood. He was treated. He got better. Now he's got HIVs under good control. His numbers look good. He does travel back and forth to India a lot and so forth. And you do a quantiferon on him, and you get these results, which are positive. The MTB minus the nil is high. But what are you going to do about this? The point here is that he had immunologic exposure to TB intensely when he was a child. He has memory lymphocytes. Those memory T cells are going to stay with him for his entire life. And even if he's completely cleared and devoid of TB organisms, he's going to have this for the rest of his life. So the answer to me is you would do nothing. And if you're going to do nothing after you get a test, then don't get the test in this kind of situation.
What if his HIV gets really bad, his CD4 counts get really low, and he gets immunosuppressed? Do you then change your?
You would work him up. You would do the basic principles of microbiology. Is you'd look for the bug. You want to find evidence by nucleic acid testing or culture or something that the bug was there, and then you would, you might treat empirically if you were really worried, but you'd really be looking for the bug. So this kind of case comes up a lot. So here's a nurse starting at a hospital. She's never really traveled or done anything, and she's always had negative skin tests, and her other lab tests look good. And you do a quantiferon on this person, and oh my gosh, they're low positive. So their MTB is 0.46 and their nil is 0.06, so their delta is 0.40. So what are you going to do now? Okay. And if you look at the actual interpretive criteria, and I don't expect you to learn this in detail, but she's basically in this range where she's got a delta of the TB minus the nil of greater than 0.35. And no matter what the other tests really show, that's considered to be a positive. This is just the thought process for her, is that she's considered to have a positive test. But wait a minute, she's low risk. She's never worked in the hospital before. She's from the US. She's never traveled. And it's a low positive. So the possible choices that I personally think are correct that you could do with this person is you could do what internal medicine doctors love to do, which is do more tests. So you could try to get a tiebreaker. You could do a skin test, see if that was positive or negative. You could repeat the quantiferon and see whether it pooched a little bit down below positive. You could do a T-spot and try to get a tiebreaker off of that. I would argue that even the last choice, which is to do nothing and allow the person to begin duty, is probably okay too, because their pre-test probability was very low. And no medical test is black and white, and all results need to be interpreted in the clinical context. So how positive is a positive? We took a look at this here. So on this graph is just a histogram of these deltas, so the TB minus the nil. This is spiking the test or maxing the test. These are trace positives or low positives over here. And there's this sort of ugly bimodal distribution. Nobody would argue that these people out here have immune memory to MTB. So either LTBI or they could be with ATBI. We can't tell LTBI from ATBI. But look how many of the tests were over here in the low positive range. So in response to this, different experts in the field are sort of putting out their own interpretive criteria for equivocal zones or gray zones for low positive quantiferon tests, especially in the low pre-test probability setting. And this makes sense. So adjusting the cutoff based on the pre-test probability is a basic principle of Bayesian analysis, as I understand it. And it's endorsed for the tuberculosis skin test. So we have different cutoffs depending on the immune status of the subject and the pre-test probability. We already have that for the skin test. And the T-spot people also have a couple of things. They have a gray zone, so they have a negative, an equivocal, and a positive. But they also have different interpretive criteria in the developed world and the developing world, which basically is high pretest probability or low pretest probability. So the other guys actually do apply these Bayesian principles in their interpretive criteria, but IGRA the QFT test has no contextual cutoffs. So there's been a proliferation of unofficial recommendations. I don't want to go into this with you guys right here and now, but just to say that these are the kind of phone calls I get, and some of you may get also about, what are we going to do about this low positive in this person with a really low pretest probability. So what are some situations where it's medically inappropriate? Almost all ER visits. When you're trying to diagnose ATBI, you need to show the pathogen. I think many inpatient tests are inappropriate unless they're really on the launch pad for transplant or immune suppressive therapy. You can't differentiate LTBI from ATBI. If there's a high pretest probability of acute TB infection, you can have the sort of anergy or false negatives. Other situations where they're maybe not going to be that useful, or an immune suppression or leukopenia, or if there's, and arguably if there's routine screening of low-test persons, of low-risk persons, this isn't really a good idea, because with the current interpretive criteria, you're going to get a lot of what are probably false positives. Previous history of being treated for LTBI or ATBI, it's not an appropriate test because people are going to be positive for the rest of their life. It's kind of like the syphilis serology. The treponemal serology we have now isn't useful for diagnosing acute syphilis. And of course, the last one, just keep harping on, if there's no diagnostic consequences for the subject or for public health, then don't get the test. So my next to last slide here has really no other points other than just to mention the learning objective and my opinions about that is the common causes of an indeterminate IGRA test and an interpretive or troubleshooting pathway. It could be biologically meaningful. That indeterminate that comes back could actually mean something about the status of the patient and not be a manufacturing tube defect or bad shaking or something. And this is a situation where you have an immune suppressed or a leukopenic patient. This test could be telling you, wait a minute, maybe I should look at the absolute lymphocyte count. Go back, what was the percent white cells, what's on the automated diff, what's the absolute lymphocyte count? Maybe that's really low and it's undiagnosed HIV infection or some other disorder that has the patient really immune suppressed. The T-spot test that I mentioned can adjust for leukopenia. So one good situation where, because that test does a FICOL, it purifies the white blood cells, then it puts a certain number per well into the reaction. So that can adjust for just pure leukopenia. Arguably, we see all these patients with the end-stage renal and end-stage liver disease. This is a whole blood test. And I'm just going back to sort of bad humors. You're expecting this whole reaction to go on in a mill of whole blood from somebody with end-stage liver disease who you can smell from the other side of the room, has all sorts of bad ketones and other toxic chemicals and stuff building up. And the T-spot, you're actually purifying the white cells out of the blood and maybe releasing them from some of those influences. I didn't really discuss this, but the manufacturers, they put in a submaximal amount of PHA on purpose, because this is what the manufacturer says is good about these indeterminates, that they're biologically meaningful. And if we blasted it with a maximum amount of PHA, we couldn't get this biologically useful information about our subjects, so we're putting in a threshold amount. There's always the issue with defective tubes. We've had 2 episodes of this in the last 24 months. Improper specimen shaking, transport, or phlebotomy. So if it's a system problem that you're noticing at your site or one clinic, it's worth looking at which clinic or who's involved with drawing the blood and making sure that they're educated to shake the tubes and transport the blood rapidly at room temperature to the lab. And occasionally we see patients who have a very, very high nil. That was that first tube with nothing in it that max the test out with a high nil. And I've gone back for QC purposes and looked at some of those charts. And some of those patients have blazing untreated leukemia, where they just have hundreds of thousands of per microliter of maybe turned on lymphocytes in the blood, or very untreated severe autoimmune disorders where they're just in a sort of an on state immunologically. So that's really my last slide. I just would say it's been a privilege to go on this journey of Mycobacterial tuberculosis diagnostics, and it's an ongoing journey. And this is a picture from a trip to India this last fall that I was lucky enough to go on. But I missed you all when I was there, too. So, so I think we have time for a few questions. Thank you very much. Yes.
As a test utilization recommendation or policy, given what you said, would it be reasonable as sort of a blanket policy to say that if you've had a convincing positive, you never get this test again in your life?
So the question was, once you've had a convincing positive IGRA test, is there ever any meaning in getting it again, or should you ever get it again? And I would agree with the questioner that, yeah, that should be, could be even put in as a policy. If you've got a positive, then whether you treat for LTBI or not, it's going to say positive.
The same would go for a T-spot or a skin test?
The same would go and the question is, would the same go for a T-spot or for a skin test? And I think, yes, but we have to stay within that particular test. So if you've had a positive skin test, that doesn't mean you shouldn't have an IGRA, because that positive skin test could have been due to BCG exposure. But I think the 2 IGRAs are, and felt by the CDC came out in 2010 with one of those MMWR position papers about IGRA tests, that little white pamphlet, and they consider the 2 tests largely interchangeable. And I think for this purpose, for this question, they would be considered interchangeable, that if you've had one of them positive, you're going to stay positive probably on both of them for the rest of your life. Keith?
David, you presented the indeterminate results all lumped together, but
Yes.
you made it very clear there's two different ways, sort of, at least, that you can get indeterminates, either
Right.
a high background or a suboptimal PHA response.
Yes.
So have you broken the analysis out to say which of those are you seeing in patients, and does that help you at all in managing?
It's overwhelmingly, so the question was with the indeterminate results, were they due to a high nil immune activation, or were they due to a low mitogen, a low positive control response? And the answer is that 97, 98% of them are due to a low mitogen to a low positive control response. So that doesn't really help us that much. Only a tiny percentage of them seem to be this immune activation state.
And in the diagnostic criteria, if you have a positive antigen
Yes.
in the context of a suboptimal PHA response, is that still indeterminate?
No, that's still considered to be positive. So we're not decreasing sensitivity. You can, as long as your TB minus your nil reaches the criteria, even if your PHA response is low, you're still considered to be a positive. Yes, Sean?
So is this T-spot test still sent to Europe, or is it done in the U.S.?
So the question from Sean was, where is the T-spot test done? And because you're dealing with living lymphocytes, time is of the essence, and sending to Europe would be impractical. So the company actually built a factory next to FedEx headquarters in Memphis, or not a factory lab. They built a lab in Memphis near FedEx headquarters, and they have a national network of shipment, and they run night shift, and but you're basically sending anticoagulated heparinized blood, room temperature, expensive shipping to Memphis, and they've got a big lab full of people who FICOL and who do the ELISpot. Yes?
So I understand the usefulness somewhat of the biological standpoint that if you can run a test, it tells you something about your patient. But has anyone had the conversation with the manufacturer that we generally know when our patients are immunosuppressed, and we have great tests for figuring that out?
Yes. Believe me, there have been, so the question was, do we really need this biological feedback about the immune status of the patient that we get from the PHA tube? And is that a good rationale for the manufacturer to put in this threshold positive amount? This has been an ongoing problem with the manufacturer over the last year, and there have been many of these webinar conference calls with hundreds of lab directors on the phone with the manufacturer, sort of having angsty sort of discussions with them. They're quite, apparently laboratory directors talk to each other on websites and gossip and so forth. I'm not on those, but some of you may be. And you know, manufacturers are sensitive to these issues and have tried to do some damage control, but they haven't changed their fundamental philosophy.
So,
Sorry, yes.
I like diagnostics, but vaccines too. I presume that if these things are targets of a diagnostic assay, they're not any good as vaccine candidates?
Well, they're actually, so the question is, are these targets good for vaccine candidates? Just in very brief, ESAT6 has been considered for a vaccine candidate, but I think the whole rationale with the failure of that MVA trial in Africa of just boosting CD4 responses is being reevaluated because that vaccine failed. Brad?
Lovely talk. Could you talk a little bit about the next generation test?
Sure.
Because the current version might have the virtues of peptides, and if you get the right peptide MHC TCR combination, it's going to give you great sensitivity.
Right.
The hole in that, of course, is if you miss that combination, that might explain some of the low positives. So more complex antigen in the newest version might have the virtue of getting better responses with the potential liability that regular production of quality antigen could be a bit of a challenge.
Yeah, so the question was really what makes sense for a next generation test, and is the current generation test insensitive because some immunogenetic background people might not have a response to the current peptides? And I think the answer to that is that the current generation test is thought to be really quite sensitive, even though those proteins are short. They have peptides from 3 different proteins, and they're the sort of, if you're familiar with Alex Sette's work with HLA supertypes, or they happen to be peptides that bind to many different HLAs. What's going into the next generation test is the company is really fixated on sensitivity and wants to add CD8 T cell responses because the current peptides are long, they're 13 to 15 mers. So they're adding 9-mers to the next product because they think that by picking up CD8 responses, they'll be able to make a more sensitive test. And in areas of high TB prevalence, that they'll increase their positivity take. I've told them, and I think most US lab directors have told them, that no, the real problem are all these low positives, all these, where the delta is 0.40 or 0.45 in a low-risk person. And you need to either change your interpretive criteria and give us an equivocal zone or give us contextual interpretive criteria, or we need to go to the healthcare authorities in the government or at our hospitals and say we need to stop doing all this testing of low-risk people. This is just a waste, and we're just creating angst and wasting money testing low-risk people.
So to follow up on that, David,
Yes.
excuse me.
Yes.
You said 500 a month, so you have 6,000 a year, and
Yes.
several hundred are probably Ajit's patients because he's on call 24/7,
Yes.
365. Fortunate to have him. But what fraction of other patients are there for good indications of utilization of this test?
So the question is, what fraction of patients are mission critical or good indications? And we have looked at who the clients are. So number one client is the pre-transplant. Number two is our HIV clinic, if you take them sort of in aggregate. And that is felt to be a good population because for epidemiologic and life risk factor reasons, they may be at increased risk for exposure to TB, and they're at higher risk to reactivate. Also, other large clients include, and this is a problematic one, is the ophthalmology clinic. There's an entity called tuberculosis uveitis, where you can't get the bug. You can't get a smear, you can't get a culture, you can't get a nucleic acid test. You have a skilled ophthalmologist looking at the pattern of the uveitis and ruling out other likely causes. And if the person's from a TB endemic country, they have this uveitis and they have a positive IGRA test, they will treat with 4-drug therapy for 12 to 18 months, or they'll send the patient to ID clinic. So actually this test is very serious, and in that ophthalmology setting is being used to make a yes-no decision for long-term toxic therapy because you can't get a microbiologic confirmation. The immigrant clinic, I'm blanking on the exact name, the international clinic that Harborview runs downtown is another large client. As I said, the digestive disease and the different clinics that give modern immune suppressants includes dermatology, GI, and arthritis use the test a lot also. I think there's an incredible number of patients that must be going on these immune suppressive therapies because we get a lot of volume. I think that means that our medical center is seeing a lot of these patients.
What happened to the PCR test a long time ago that they thought that would be a good test for diagnosing it and sensitivity? Whatever happened to it?
So the question was, what happened to the PCR test for MTB? And I think that it's still there. There are different versions of nucleic acid detection, and whether it was PCR or some high-tech sister of PCR, I'm not sure, but that are used on sputum specimens or body, tissue biopsies or spinal fluids or pleural fluids. That's definitely there. But that's the demonstration of the microorganism and demonstration of active infection. And the goal here with the IGRA test is really the demonstration of immune memory to Mycobacterium tuberculosis, to which we think there are a very small number of bacilli probably in the lung, but we just can't access that for a PCR-based diagnosis.